Hello everyone, dear friends and colleagues in MENA region and outside MENA region. For the second consecutive year, the IDF MENA region and its scientific committee has scheduled a series of monthly MENA scientific webinars. Last one was on May 21st. Today, it's deep honor and pleasure for me to moderate the webinar about program injectable therapy in diabetes. On this occasion, I would like to thank our experts, speakers from MENA region, Professor Rayaz Malik, Professor Kenza Ben Omar, and Professor Mohammed Hassanin, who are going to give lectures about this important topic. This session with 3 lectures promises to be very attractive and informative by the quality of the teams chosen and by the reputation of the speakers. I wish everyone an excellent session. Otherwise, I invite the participants to write their questions in the question box. The answers will be given by the speakers at the end of the lectures. Our first speaker is Professor Rayaz Malik. Professor Rayaz Malik is from University of Qatar. He was appointed as Professor of Medicine and Consultant Physician in Central Manchester University Teaching Hospital and the University of Manchester. His research focuses on the pathogenesis, assessment, and treatment of diabetic and other peripheral neuropathy and central neurodegenerative disorders. He was the president of NeuroDiab, the Diabetic Neuropathy Study Group of the EASD. He was also an associate editor of Diabetic Medicine and remains an associate editor for Journal of Diabetes Complication. Let's start, Professor Rayaz Malik. You have 30 minutes.
Thank you, Dr. Jamal, ladies and gentlemen. So the topic of my 30-minute talk is New Frontiers for Injectables. These are my disclosures. I have received honorary for lectures for Novo Nordisk, Pfizer, and Sanofi. And this is where I start. And this is really the objective of the talk today, which is to address why an individual with diabetes, and particularly an individual with diabetes and a myocardial infarct, will die 12 years earlier than a person who does not have diabetes. Is it simply related to the fact that we are not achieving adequate glycemic control? It is true that in both type 1 diabetes and type 2 diabetes, most countries report a HbA1c of around 8%, which, given the number of therapies, particularly one of the major injectables that we have, insulin, which actually has no bottom limit, is surprising. However, and in the Middle East, actually the average report is maybe as high as 9.6%. But the problem is the following, which is that in our quest to achieve optimal glycemic control, we have to balance that against 2 major abnormalities, which is hypoglycemia and weight gain, and subsequent increased cardiovascular risk. And this was highlighted in particularly a trial called the Accord trial, where the target HbA1c was ideal, 6.4%. But we discovered that the remedy that we were offering patients maybe is worse than the disease itself. Why? Because although we were prescribing metformin, sulfonylureas, TZDs, and particularly insulin, actually there was an elephant in the room. And that was that there was something that went wrong that we couldn't explain. We were achieving the best glycemic control with the majority of people on insulin, and yet we were not achieving what we wanted to achieve, which is a reduction in cardiovascular outcomes. And that's ultimately the end game. It is to try to prevent patients from dying 12 years earlier. But by simply treating the number, HbA1c was almost normal, and yet more people were dying. So in the Accord trial, you can see there was an excess mortality, cardiovascular mortality. Even in the other trials, not significantly improved. Even in the UK PDS, not significantly improved. And then people said, well, maybe we're not benefiting the cardiovascular diseases, but we are maybe helping with the microvascular complications. Well, not really, because again, this is the meta-analysis looking at patients with type 2 diabetes who were compared essentially with optimal glycemic control, that is HbA1c of 6.8 compared to 7.7. What happened to the microvascular complications? Well, quite simply, if you look at nephropathy, that is dialysis, transplant, renal death, then actually there was a 20% improvement, but this was primarily driven by the fact, not by improving glycemic control, but the fact that these patients were also on statins and they were on ACE inhibitors. For retinopathy, marginally improvement, 13%. And for neuropathy, actually no improvement, 2%. So to me, this is insanity, doing the same thing over and over again and expecting a different result. That is, treating patients with the same old insulin, same old metformin, same old other drugs, and yet we haven't really improved their outcomes. So if we look at the evolution of diabetes drugs, this is a really instructive slide because it shows us the history of where we started and where we've come to. So we started with insulin in the 1920s. We then had sulfonylureas and biguanides, and then we had nothing for a long period of time. But now we have multiple new therapies, particularly some new injectables, and I'll focus on those. So we have newer insulins. We have even got the amilonomimetics, which is only one actually, and it's not prescribed very widely apart from in the USA. And of course, we have the GLP-1 receptor agonist, and we have now the combinations of the GLP-1 receptors with the insulins. So let's look at what injectables are out there that actually have been shown perhaps to have a benefit in terms of not only improving glycemic control, but reducing cardiovascular risk in type 2 diabetes. This is a very recent review in the New England Journal of Medicine, which breaks it down into the medications that are available. So insulins, there are the basal insulins, of which we have the standard isoflanes, but there are the newer insulins like glargine, detamir, degludec. And then you have the bolus insulins, which include the older established ones, lisbraspart, but now the newer ones, glulisine. And of course, there is the inhaled insulin as well. Now, in theory, these insulins can lower glucose, hemoglobin, glycated hemoglobin level. There is no lower limit because we know how they work and they work very effectively. And in terms of the choices we have multiple choices. So we have the dependable glargine, Lantus, the newer, more concentrated, Toujeo, and the even newer therapies, the long-acting insulin. And for the fast-acting insulin, again, we have the established ones, so the Novarapids and the Humalogs, but we also have the newer Fiasp, which is supposed to be much more physiological. We then move on to something that I must say I've never prescribed, but is available, the amylin agonists. And I'll talk to a little bit about those, but these do have a limitation in that the HbA1c is reduced by only about 0.5%. But they do mimic the action of a natural hormone that is released by beta cells at the same time as insulin, amylin. And it does have a benefit in terms of weight, but also on glucose. And we've only got one type of drug that's out there, which is this simin pen, which is the 60 milligrams or micrograms of the 120 dose. The other major area, of course, of injectables is the GLP-1 receptor agonists, of which there are many. Okay, so In terms of insulins, we know that they do improve blood sugar. Some of the newer ones perhaps have less hypos, but do they improve cardiovascular outcomes? Well, the Origin trial showed us that actually, even if you start very early with insulin glargine and you have achieve HbA1c which are almost normal, actually you do get one outcome, which is severe hypoglycemia episodes increase significantly. So that's a natural consequence of treating somebody with insulin. Does it improve cardiovascular outcomes? No. Compared to standard care, which would be oral therapies, absolutely improving glucose down to the near normal levels does not improve outcomes with insulin glargine. One of the reasons, I think, so the conclusions would be that despite HbA1c of 6.2% with insulin, no cardiovascular benefit. One of the reasons, I think, is probably the fact that people gained weight. What about looking at the safety of degludec versus glargine, because degludec is better? Well, we do know from the big DEVOTE trial in type 2 diabetes that actually overall hemoglobin A1c really no different between degludec and glargine. One possible benefit is that degludec has less severe hypoglycemia and less severe nocturnal severe hypoglycemia. But does this translate out into better cardiovascular outcomes? No, not really, because the primary endpoints, primary composite outcomes, no different between glargine and degludec. Death from cardiovascular cause, no different. Non-fatal myocardial infarction, no different. Non-fatal stroke, no different. So yes, the newer insulins, the likes of degludec, the likes of TJO, do have a benefit in terms of less hypoglycemia, but no apparent benefit in terms of cardiovascular outcomes, which is the ultimate end game which we are trying to treat. What about the newer insulin? I talked about this new FIASP, which is supposed to be more physiological, much faster acting. So in the clinical sense, if you have a patient who really doesn't want to be injecting 15, 20 minutes before they eat, they can inject even after they've eaten. The studies suggest that there is some physiological benefit. So these are studies that have been done. So this is one particular study that shows that compared to insulin aspart, the faster aspart actually achieves better postprandial glucose levels at all time points and has a slightly better HbA1c. So in terms of optimization with the newer FIASP, there is some benefit in terms of glucose control, but there are no outcome trials with this particular therapy. There is also, you'll be aware of these new co-formulations which are coming out, which is insulin degludec with rapid-acting insulin. So IDEGASP, for example, and I know Mohammed's done the trial in Ramadan, which does show that actually it works effectively, more effectively than Novamix. So what is this? This is basically insulin degludec. Newer formulation is in 70%, IASP 30%, mixed together, and is supposed to be better in terms of its overall effect on glycemic control. I must say, when I first came across this, I thought, how can this differ from Novamix 3070? Surely there can't be that much difference. Well, the co-formulations actually, because they contain two biologically active solutions, as opposed to the Novamix or premixes, where you actually have a suspension of one biologically active substance, and then that is slowly released. Because in this co-formulation, you actually have the insulin degludec and IASP together. They actually mimic physiologically the insulin secretion more closely, and so they avoid the shoulder effect and the variability of the proton-animated premixed insulins, such as the Novamixes. And they also simplify the insulin regimen. And so the variability in glycemic control is less, there is more complete 24-hour basal coverage, and you don't need to resuspend. So these are the apparent advantages of the co-formulations as opposed to the standard premixes. And if you look at multiple trials, and I'll just choose one, if you compare, for example, this study looked at 440 patients with type 2 diabetes who were already on maximal oral therapies, metformin, DPP-4, and glitazone. And they were simply randomized to receive either the newer co-formulation IDEGAS or the standard bias. And what you see is, in terms of HbA1c, no difference. But there is a benefit in terms of both confirmed hypoglycemia and nocturnal hypoglycemia. So there is less in the co-formulations compared to the standard mixed insulins. The big kind of, I suppose, new news is the once weekly insulin. So this is actually icodec, which is, again, Novo up to their usual kind of, innovations in terms of substituting amino acids, adding fatty diacids, and coming up with a formulation which is truly allowed to be injected just once a week in your patients. They don't have to inject every day. So this is one particular trial published recently in the New England Journal of Medicine. Julio Rosenstock was the first author. What you see is the weekly dose of icodec as compared to the weekly dose of glargine. So essentially you inject just once a week, but the total dose is roughly the same, although it's less overall, 33 units per day, compared to glargine, which is 41 units per day. So overall, you would inject 33 times 7, but here you see you're injecting more of the glargine. And the outcomes are essentially that the icodec insulin as opposed to the glargine, this is a baseline, you can see comparable, but after 26 weeks, there is an overall improvement in postprandial and fasting blood sugars in the icodec group compared to the glargine group. Small, but significant. And there is an overall improvement in glycated hemoglobin as well, but not significant. So by about 0.2%. But to me, actually, what this tells you is that this is at least comparable, if not slightly better, in terms of achieving a HbA1c less than 7% was actually comparable, 72-68, but less than 6.5% actually, 49% compared to 39% in the glargine arm. But the key thing is injecting only once a week, as opposed to once every day. So the newer insulins, I think overall, they have equivalent HbA1c, but less hypos, no obvious cardiovascular benefit. So how do you achieve more cardiovascular benefit? Well, I think the key has to be in relation not to particularly the hypos, but what we do to our patients with these injectables in relation to fat. And Jocelyn put this very aptly. He said, way back when insulin was just being invented, from an excess of fat, diabetes begins, and from an excess of fat, diabetic patients die. And there's no doubt. And I asked this question, I think, as a registrar or something. And I said, what if you could lower glucose with less hypos and weight loss? And at that time, I remember my consultant telling me, don't be stupid, Riaz. Just doesn't happen. We don't have the therapies that allow you to lower glucose without hypos and weight loss. It's true. At that time, back in 2006, actually, what we had is SUs and TZDs were on the scene. We certainly didn't have SGLT2 inhibitors or GLP-1 receptor agonists. And at that time, most of the therapies we gave lowered glucose, but caused hypos and also caused weight gain. But we now are in a different era. And really, actually, the era started with this newer kind of therapies that allow us to lower HbA1c without causing weight gain or actually inducing weight loss with this, which is something called pramlintide, which is an analog of amylin, which is a synthetic version of human amylin reduced by beta cells. And in fact, this was approved by the FDA back in 2005. What it does sounds very similar to the GLP-1 agonists. So it actually, slows gastric emptying, it suppresses postprandial glucagon, and it also has a central effect on appetite modulation. You might think, well, that's actually a GLP-1 agonist. It isn't, because actually it's not as effective. However, it is FDA approved and indicated for the treatment of both type 1 diabetes or type 2 diabetes in combination with insulin. And one of the key things I think why it isn't as used is because it has to be administered before each meal. So it's just an added burden in terms of injections, and the efficacy you will see is not as good as the GLP-1 agonists. So these are the data. So pramlintide, gastric emptying is improved. You can see it's slowed down with the 30 micrograms and 60 micrograms in terms of the percentage gastric emptying 1 hour after breakfast. You can see less compared to placebo. There is an effect on glucagon, plasma glucagon. You can see pramlintide suppresses glucagon secretion. There is an effect, again, it is the type 2 diabetes with regular insulin, mixed meal. Again, normally you get a rise increment in glucose. You get this almost balancing out. And if you look at the HbA1c effect, what you see is week 4, week 13, week 26, is around about a 0.5% reduction in HbA1c. You can also actually reduce the insulin dose, and you can also have a marginal effect on weight. So yes, this sounds very much like a GLP-1 agonist, but it's not, and it's not as effective. And it's part of the reason why perhaps it hasn't been as successful. And in terms of cardiovascular safety, we don't really actually have any major long-term data for this. All we have is short-term studies of up to about a year that suggest that there is cardiovascular, I would say, equipoise. That is, there is no increase in cardiovascular risk, and nor is there any major benefit. But we have to then come on to GLP-1. So GLP-1, as you know, was discovered in monkfish in the 1970s. Remember, we didn't get it approved until the 90s. And we know that Dr. John Eng found it in the Gila monster in 1996. And it's part of the reason why the amylin agonists haven't actually done as well as they should. Because amylin, it's interesting, is developed. So amylin is a company in San Diego which developed both the amylin agonist and the first GLP-1 agonist, exenatide. So pramlintide actually was approved in March 2005, and exenatide was approved in May 2005. And you can imagine, exenatide was the big hitter that allowed amylin to be sold up to, I think, J&J and then AstraZeneca for $7 billion. And really, that is what talked. Money talked, and people thought, well, exenatide is the big money getter that we ought to be chasing. And so, because of that, there is not as much emphasis on pramlintide. But we now know that there are multiple drugs. Liraglutide, approved August 27th, has a cardiovascular indication. Dulaglutide, September 2019. And of course, semaglutide, January 2020, has not only the glucose lowering indication, but as a prevention of cardiovascular events. And that's ultimately what we're trying to achieve. If we look, clearly the injectables, the GLP-1 agonists, multiple therapies, multiple major trials, all show one single outcome, which is leader with liraglutide, sustained with semaglutide. Albiglutide, again, that's another financial story why it's not being promoted, but we won't go into that. And dulaglutide, of course, with Rewind, all showed early and significant improvements in cardiovascular outcomes, which is why they are prescribed so much, and which is why they are recommended with a class 1A recommendation for the treatment to prevent cardiovascular events in type 2 diabetes. We know that all GLP-1 receptor agonists actually are not created equal from a synthetic basis in terms of the fact that exenatide and lixisenatide are exendin-based. That is, they are very different in terms of their structure compared to liraglutide, semaglutide, dulaglutide, and albiglutide. And that may be part of the reason why trials like the Excel, Freedom, Elixir didn't do well in terms of cardiovascular outcomes, whereas Leader, Rewind, Harmony, and Sustain have. And indeed, we show that there is non-inferiority for these earlier exendin-based drugs as opposed to superiority for the human GLP-1 analogs. So all men are, Lincoln said all men are created equal, but Malik would say that all GLP-1 receptor agonists are not created equal. And indeed, if you look at the trial outcomes, you see that the exendin-based therapies like lixisenatide did not have an improvement in MACE outcomes, whereas liraglutide, semaglutide have. And exenatide once weekly even doesn't have that outcome benefit. So we have, of course, semaglutide, which, as you know, it's probably got the best data at the moment in terms of the weight loss, in terms of the HbA1c reduction, but also the cardiovascular outcomes. So you can see here, this is the SUSTAIN-6 trial, HbA1c 1.1 to 1.4%, weight loss 2.9 to 4.3 kilograms, systolic blood pressure 1.3 to 2.6 millimeters of mercury, and you're talking really quite quickly an improvement in terms of outcomes, weeks, and this is maintained with almost a 26% improvement and superiority. We now also, you will be aware that just been approved by the FDA, we have the once weekly semaglutide, the higher dose 2.4 milligrams, which has been approved for overweight or obesity. And this is the 68-week trial published in the New England Journal of Medicine in just patients who were overweight with 2.4 milligrams. Shows you in terms of weight loss, almost a 16 kilogram weight loss in semaglutide, and that is now FDA approved for weight loss in non-diabetic individuals. But, and there is a but, the cost, some people say maybe as much as $10,000 annually. And I think that's something that we need to address, because that is, again, a significant amount which most people can't afford. The other GLP-1 agonist, which is actually the exendin base, which is the GLP-1 exenatide, which has an appeal, but unfortunately at the moment has not managed to pass through the FDA hurdles. So this is, of course, the ITCA 650 system, which has massive appeal. Why? Because this is a once 6 monthly or 12 monthly GLP-1 that you simply insert subcutaneously into the skin, and you can see these are long-term data that shows slow release of exenatide. The outcomes are not as impressive in terms of HbA1c reduction, but nevertheless, there is an improvement in HbA1c. There is a reduction in weight of about 3 kilograms. And you can see here, change in HbA1c with the ITCA 650, the 40 micrograms and the 60 micrograms compared to placebo. There is a reduction in HbA1c and weight. And actually, compared to sitagliptin, there is a greater HbA1c reduction, 1.5% compared to 0.8%, and also a greater loss of weight, 4 kilograms as opposed to 1.3 kilograms. However, the FDA so far have rejected this therapy. It went in front of the FDA actually September 2017. They were actually, I don't know what they came back with something about manufacturing. And now in March 2020, it's again been rejected. So they need to do more studies, and I'm not sure if that will happen. So finally, GLP-1 receptor agonists on their own, we know are beneficial. Basal insulins, we know are beneficial for lowering glucose, but because of the weight gain, I think we don't see the cardiovascular benefits. So in the future, could we combine the two and get a better outcome? Well, we know basal insulin reduces HbA1c, reduces fasting plasma glucose, and partially reduces postprandial glucose. We know GLP-1 therapies reduce HbA1c, fasting plasma glucose, and more so postprandial glucose. So what if you combine the two? Well, maybe you'll get a better HbA1c reduction, fasting plasma glucose, and postprandial glucose. And in terms of side effects, we know that basal insulin increases weight, increases hypoglycemia, has no effect on nausea. GLP-1 agonists reduce weight, no effect on hypoglycemia, but do have an incidence of nausea. So if you combine the two, maybe you can overall get a reduction in weight, less hypo, and perhaps less nausea, because you're going to have less dose of the GLP-1. In terms of the two therapies that are out there, there are two, which is one is a combination of liraglutide with insulin degludec, which is Injectable. So this is a basal insulin combined with the GLP-1 receptor agonists, degludec and liraglutide. It's a 3 ml pre-filled pen, and you basically start it at one dose and you titrate up the dose. Once daily administration, independent of meals, in a single pen device. Glycemic control throughout the day with the fasting plasma glucose reduction, and also postprandial glucose coverage at all meals. There's a steady titration, and essentially the data, and there are again multiple trials, dual trials, but one set of data shows if you compare Injectable, which is the ones long-acting insulin with liraglutide with essentially basal bolus insulin in patients with type 2 diabetes uncontrolled on basal insulin, then what you find is the following, that HbA1c is actually comparable. So head to head against a basal bolus, Injectable performs just as well. But what you see is a benefit in terms of weight. So there is weight loss as opposed to weight gain, and confirmed hypoglycemia. There is less hypoglycemia compared to the basal bolus. Studies in terms of cardiovascular outcomes need to be done. Similarly, there is a combination of lixisenatide with long-acting basal insulin, insulin glargine, and this is again similarly a pen which combines the two. And again, there is a study that has compared basal bolus insulin against the GLP-1 with insulin, the Soliqua. And what you actually see here is that overall, there is actually a very small benefit in terms of HbA1c. But overall, if you look at 3 different endpoints, which is HbA1c less than 7%, no hypoglycemia, then actually you have a significantly better proportion of patients who are on Soliqua compared to basal bolus insulin. So you get better HbA1c, less hypos. Also, if you look at the endpoint of HbA1c less than 7%, no weight gain, again, as you'd expect, because of the GLP-1 agonists, you get a greater benefit in terms of outcomes. And if you look at the combined HbA1c less than 7%, no weight gain, no hypo, again, the Soliqua does better in terms of outcomes of proportion of patients who achieve this. So overall, it appears that the combination of GLP-1 with insulin is something we need to look forward to in terms of cardiovascular outcomes. They also appear to have comparable HbA1c reduction, but less hypos, and of course, less weight gain. And one would think that that might tip it in the balance of better cardiovascular benefits, but we need to wait the outcome of these trials. So I'd like to finish there and thank the audience, and like to say that from Muhammad Ali, a quote which I love, which is, "The man who views the world at 50 the same as he did at 20 has wasted 30 years of his life." Thank you.
Thank you, dear Professor Rayaz Malik, for your very interesting presentation about new injectable therapy in diabetes. Now I invite the participants to write their questions in the question box. The answer will be given by the speakers at the end of the lectures. Now, our second speaker is Professor Kenza Ben Omar, who are going to present challenges in initiation or intensification of injectable therapy. Kenza Ben Omar is endocrinologist, diabetologist, currently based in Casablanca. Ex-assistant professor in the Department of Endocrinology, Diabetology, Nutrition and Metabolic Disease at Lille University Hospital in France. Ex-teacher at the University of Medicine of Lille, PhD in Diabetes Cellular Therapy at the INSERM Unit Laboratory in Lille. Professor Kenza Ben Omar, it's your floor. You have 30 minutes.
Thank you very much, Professor Abdelkader, for the presentation. First, I will thank you for the invitation. I am so happy to be with you and participate at this meeting. I will start my speech about challenges in initiation or intensification of injectable therapy. What are the issues on the injectable therapy? the delays in initiation and intensification of insulin therapy, how to intensify basal insulin therapy with GLP-1 receptor agonists, what are the barriers, the clinical barriers and the patient's barriers in the initiation of injectable therapy, why does intensification of insulin therapy not happen in patients with type 2 diabetes, and what are the options for type 2 patients and controlled on basal insulin therapy. We will start with a clinical case. A 64-year-old woman with type 2 diabetes years. Her BMI was 33. She has a normal blood pressure controlled with antihypertensive therapy, and she has A1C 8.2 on metformin, vildagliptin, glimepiride. So this patient has hypertension 30 months ago. You know that diabetes is a chronic. This progressive nature of diabetes should be regularly and objectively explained to patients, and providers should avoid using insulin as a treat or describing it as a sign of personal failure or punishment. As you know, at UCAPDS, at the time of diagnosis, more than 50% of the function was already cell is liver or brain. You know, the UCAPDS study has shown us that improving complications, every 1% drop in A1C can reduce the 43% lower extremity amputation or fatal perfect vascular disease, 37% microvascular disease, 90% cataract extraction, 60% heart failure, 40% myocardial infarction, and 12% stroke. Otherwise, the early insulin treatment prolongs beta cell function and promotes the metabolic control compared to other hypoglycemic agents. So, what are the advantages of insulin therapy? The basal insulin therapy is oldest of the currently available anti-glycemic therapy. This is most effective in improving glycemia and achieving therapeutic goal, and has beneficial effects on triglyceride and HDL. But there are the disadvantages with weight gain and hypoglycemia. So the question we ask ourselves every day, what type of insulin should we start? The insulin regimen to be implemented depends on the level of overall hyperglycemia. We know that the contribution of fasting glycemia is higher in the highest A1C. On the other hand, the closer we get to the goal of A1C, the GPP we have to control. So when we start with the basal insulin, there is a rational, predominant fasting hyperglycemia. This is a simple titration, 1 injection a day. Start with 10 or 20 units at bedtime and adjust based on fasting glucose, self-adjustment of insulin dose. This basal insulin is effective, A1C reduction by 1 to 2.5%, and can be combined with oral agents. This insulin therapy, the basal insulin therapy, is safe, with lower risk of hypoglycemia, with less weight gain, and the injection can be done at any time. In the 40 trial, the 40 demonstrated the benefit of initiating with basal insulin in type 2 diabetes inadequately controlled by oral agents compared with prandial premixed insulin. People initiating basal insulin experienced significantly lower rates of hypoglycemia and less weight gain compared with prandial premixed insulin. And this study also showed that over the long term, a premixed insulin with a midday prandial bolus was not as effective as basal plus prandial insulin at achieving the goal of A1C. So there are a lot of regimen. There are a common strategy that depends on goal of A1C, the patient's style life, the comorbidity, and the cost of treatment. Moreover, uptitrating basal insulin may not achieve A1C targets and may increase risk of hypoglycemia. When we reach at doses of 1 unit per kilo, we must intensify the injectable therapy. Also, the patient adherence with basal insulin is suboptimal. Only 43% take the treatment. 1/3 of patients admitted to omitting doses or not adhering to treatment regimens. The primary reason given by the patients for insulin omission were predominantly due to the inflexibility of the regimen. Insulin reason such is too busy, traveling, or challenging to take it at the same time in the day. So what about the 2021 guidelines, the ADA guidelines? As you know, the consensus of ADA recommends to consider the place of GLP-1 receptor agonist prior to insulin. And if basal insulin has been titrated to an unacceptable fasting blood glucose level, or if the dose of 0.5 units per kilo per day and A1C remains above target, you must consider advancing to intensified insulin regimen. This intensification can be done by adding dose of prandial insulin. So what are the benefits of GLP-1 receptor agonists in association to insulin? First, low risk of hypoglycemia, increased insulin secretion in a glucose-dependent way, improvement in cardiovascular markers like blood pressure, triglyceride, low-density lipoprotein cholesterol, use it as an alternative to metformin or add-on, and promote weight loss. And as you know, and as presented by Dr. Rayaz, overall GLP receptor agonist has extensive cardiovascular evidence based on which it could be used as a desirable agent for glycemic control while covering risk of cardiovascular death, of non-fatal myocardial infarction, and non-fatal stroke, and hospitalization for heart failure. But unfortunately, very few type 2 diabetes patients are on target when treated with insulin compared with other medication like diet or exercise or one diabetic agents. So the question, why does intensification therapy not happen in many patients with type 2 diabetes? First, the clinical inertia, the physician barriers, inexperience with using insulin, fear of hypoglycemia, not buying to A1C targets, the patient's barriers, like insulin carries, the educational issues about insulin dose increases, and the progressive nature of disease. And very often, this intensification must be done quickly after the basal therapy, but is not done. And there are many options for type 2 diabetes patients and controlled on basal insulin. For example, add another oral agents like DDP4 inhibitor or SGLT2 inhibitor, add a short-acting insulin at mealtime, or switch to premixed insulins, or novel insulin combination, like modern short-acting plus long-acting insulin analog combination, or the fixed combination of basal insulin and GLP-1 receptor combination. So we will analyze the two last options. When we compare this trial, compare the option of association of high degludec with the aspart compared to basal bolus regimen. This trial showed that mean A1C decreased by 1.3% in the high-deg aspart group and by 1.5% in the basal bolus group. So the non-inferiority of high-deg aspart versus basal bolus is not confirmed, and the proportion of patients achieving A1C less than 7% after 26 weeks was similar for high-deg aspart and basal bolus regimen. And what about the combination, the fixed ratio combination of basal insulin and GLP-1 receptor agonists? We have two different daily fixed dual combination products containing basal insulin plus GLP-1 receptor agonist, the iDeglira with liraglutide and degludec, and the iglarixy, the lixisenatide with insulin glargine. So the complementary effects of basal insulin and GLP-1 receptor agonist therapy decreased A1C, decreased fasting glycemia, and postprandial glycemia without less side effects, without increasing side effects, the gastrointestinal effects. So the utility of fixed ratio basal insulin with GLP-1 receptor agonist combination in clinical practice, there are many advantages: low risk of hypoglycemia, the weight loss, the reduced frequency of gastrointestinal effect due to the slow titration with low initial dose of GLP-1 receptor agonist, and increased patient acceptability. So what are the candidate patients for this combination? I think the patients with A1C above 7 or even 8%, the advanced type 2 diabetes, some complication already, insulin therapy delayed for some time, at higher risk for hypoglycemia, and patients on overweight. So the combination of basal insulin with GLP-1 receptor agonist has a scientific basis. This combination has potent glucose lowering action and less weight gain and less hypoglycemia. The basal insulin analogs can have a controlled nocturnal and fasting glycemia. GLP-1 receptor agonist pronounced postprandial glycemic control, especially short-acting agents, is simple to initiate, achieve A1C targets with lower risk of hypoglycemia and with lower gain weight. When we compare a GLP-1 receptor agonist with basal insulin versus basal insulin plus the prandial insulin, the two combinations there is no significant difference in change in A1C, but there is a significant more efficiency for change in weight and risk of hypoglycemia. So having GLP-1 receptor is equally effective comparing to having prandial insulin with fewer injections, improved adherence, patient adherence, less glucose monitoring required, lower insulin dose, weight benefit, and less hypoglycemia. But the cost of this combination is more expensive. As presented by Dr. Rayaz Malik, we have two fixed ratio combination, insulin degludec with liraglutide and insulin glargine with lixisenatide, Duxultofide, and Soliqua. The rationale and the benefits, there are many benefits, provides pathophysiologic based treatment, targets bypassing at postprandial glucose. The single injection may reduce out-of-pocket costs. This combination is safe, effective initiation and titration algorithm, avoids uncertainty regarding titration and titrating individual components, and minimize delays in achieving glycemic control. The dual program studied the efficacy and safety of this combination. The dual one trial, as you know, is comparing the efficacy and safety this 26-week randomized parallel 3-arm open label multi-center treat to target trial comparing fixed ratio combination of insulin degludec and liraglutide versus insulin degludec or liraglutide alone. After 26 weeks, mean A1C had decreased by 1.9% to 6.4% with Ideglira, by 1.4% to 6.9% with insulin degludec alone, and by 1.3% to 7.1% with Lira alone. So Ideglira was non-inferior to insulin degludec, but superior to Lira alone. So Ideglira combines the clinical advantages of basal insulin and GLP-1 receptor agonist, resulting in improved the glycemic control compared with its components given alone. The dual two investigate the contribution of Lira components of Ideglira versus degludec alone and efficacy and safety in patients type 2 diabetes. The IDEC dose alone or as part of Ideglira was equivalent. So A1C decreased by 1.9% with Ideglira and by 0.9% with Idegludec alone. And the mean weight reduction with Ideglira was 2.7 kilograms versus no weight changes with degludec alone. So the dual 2 trial showed that Ideglira achieved glycemic control, and the reduction of A1C is superior to that of IDEG alone at equivalent insulin doses without high risk of hypoglycemia and with benefit of weight loss. The dual 3, this trial aimed to investigate the efficacy of Ideglira in controlling glycemic control in adults type 2 diabetes who were inadequately controlled on GLP-1 receptor agonists and oral agents. So after 26 weeks, A1C reduces, and the reduction of A1C was superior in the Ideglira group versus GLP-1 receptor agonist. So mean A1C reduced from 7.8% to 6.4% with Ideglira, and from 7.7% to 5%. This study assessed the efficacy of insulin degludec versus insulin glargine across categories of basal A1C BMI, and fasting glycemia. With Ideglira, mean A1C was reduced across all baseline A1C, fasting glycemia, and BMI categories, with significantly greater reduction with the Ideglira versus Glargine. And the dual 7 in patients with uncontrolled type 2 diabetes on basal insulin, prandial insulin may be initiated, and we assess the efficacy and safety of initiated insulin degludec-lira fixed ratio combination versus basal bolus regimen. And in this trial, we show that A1C decreased from 8.2% to 6.7% with Ideglira versus 8.2% to 6.7% in the basal bolus regimen. So there is the reduction of A1C is equivalent in the two arms. And in this trial, the other combination of lixisenatide with Glargine, this trial evaluates efficacy and safety of Lixilan, a novel tetrable fixed ratio combination of insulin Glargine and lixisenatide compared with both components, Glargine or lixisenatide, given separately in type 2 diabetes patients. And as you, this trial showed that there is greater reduction in A1C from baseline 8.1% to 6.5%, and with in the group Glargine lixisenatide, and due to from 8.1% to 7.2% in the to 6.8% in the Glargine group. So A1C reduction close to near normal glycemia without increases in either hypoglycemia or weight compared with Glargine, and had low gastrointestinal adverse effects compared with lixisenatide. So, in summary, we must identify candidates for insulin therapy or GLP-1 receptor agonist, or the combination of both of them. Select appropriate insulin replacement, but above all, our challenges are to fight against therapeutic inertia and take advantage of new formulation and new insulins like concentrated insulins, the long-acting U30 Glargine, or inhaled insulin, or the fixed combination injectable therapy with basal insulin and GLP-1 receptor agonist. So thank you very much.
Thank you, dear Professor Kenza Ben Omar, for your very informative presentation. Now, our third and last speaker is my friend, Professor Mohammed Hassanin. He's going to talk about simple tools to overcome challenges for injectable therapy. Professor Hassanin, he works in Dubai Hospital, Dubai Health Authority, Professor of Medicine in Gulf Medical University and UAE Cardiff University School of Medicine, Chair of Diabetes and Ramadan International Alliance. He the first author and co-author in almost 80 papers in various topics, particularly diabetes and Ramadan, where he co-authored recommendation on this subject for the IDF in 2016, ADA in 2005 and 2010. He also developed 3 educational programs for diabetes and Ramadan in collaboration with various international centers. He is the associate editor for Diabetes Research and Clinical Practice Journal, as well as Dubai Diabetes Endocrinology Journal. Before giving the floor to Professor Hassanin, I invite the participant to write their question in the question box. The answer will be given after the conference of Professor Hassanin. Professor Hassanin, it's your floor. You have 30 minutes.
Thank you very much, Professor Jamal. Assalamu alaikum, everyone. It's a great pleasure to be with all of you across the MENA region and beyond. Now, we've heard two excellent presentations by Professor Malik and Professor Ben Omar regarding the new insulins, the new GLP-1s, the combination of both, and the challenges in the intensification and initiation of injectable therapy in general. I would like to address something a bit more of a simple tool of how can we overcome challenges. Now, we've heard in the last two discussions about the importance of achieving targets. It's very important to achieve targets. It makes everybody happy. This is special for Professor Riaz. Being a Liverpool fan myself, I was extremely happy when we achieved the target of the Champions League, seeing Mohamed Salah lifting the trophy, and I was very happy to be there myself in Madrid 2 years ago. But we all are aiming for targets. Unfortunately, as both speakers have presented, many of our patients, despite all the modern therapy that we have, are not achieving targets. Even in the best societies, in the best healthcare systems, we are still not achieving targets. We have heard from the presentations that all international guidelines are really stressing the importance of using injectable therapy when the time is right. In the past, that used to be insulin. Now it is GLP-1, unless the HbA1c is above a certain target. And we've heard just from Professor Kanza Ben Omar about the problem with physicians' inertia. True, very true. Many of the studies have shown that we as healthcare professionals, we initiate insulin far too late. So, of course, we need to avoid inertia. When you look into data from many Western societies, we initiate insulin at a pretty high level of HbA1c, not really at the target of above 7.5 for 3 to 6 months. So really, it's important that we start to think of the reasons for this. Now, some of the reasons have been said by our colleagues. This is a slide that shows clearly that the problem from patients' point of view, as well as from many of us, is the hypoglycemia, as well as the complexity of treatment. And then the hypo make the patient do not comply with therapy. So we end up with hypoglycemia. So hypo leading to hyperglycemia. From a physician point of view, is our patients, we say our patients are not adhering to treatment and we need a simpler insulin titration. The story from our patient's perspective is different, is related to the hypo, the weight, the complexity, and the issues related to driving. So how can we overcome the barriers? Of course, if we can get better injections of better pharmacodynamics, whether it's a GLP-1 or insulin or something else, that will be great. But that's not just the only answer. We really need to think of why, what are the simple tools? What can I do today and tomorrow in my clinic, in my practice, that will make a difference? Unfortunately, in many cases, we as doctors, we as healthcare professionals, as nurses, pharmacists, dietitians, in many cases, we are to blame. We make the patient feel that going on an injection means that they have failed. It's when we say failure of oral therapy, rather than progression of the disease. And many cases, I remember my mother, rahmatullah alayha, she used to say to me, see how many tablets I'm taking. My mother used to be a very active person. She would go walking for half an hour to 1 hour every day, and she would eat very healthy food. However, I was saying to her, Mama, this is the disease progression. This is nature. If you were not doing all what you're doing, it could have been worse. But in many cases, what we say to our patients is a threat. We threat our patients with the problem that you're not doing what you should do, and you need to go to insulin. So insulin makes patients feel they failed. It's the punishment. And the IDF say to us, we need to explain to the patient with diabetes that insulin is a fantastic option. Insulin is why they have problem with diabetes. The fact that we have insulin is a great benefit, and many people will need insulin in their lifetime with diabetes. Some will not, but many will do. So instead of feeling that insulin is a negative thing, is a punishment, they need to feel that it's a great bless. And part of this is really our communication. Let's not forget, our patients come to us and all of a sudden we tell them, don't smoke, don't eat this, don't drink that. And not only this, but we are treating an asymptomatic condition and we bombard them with tablets that they have not been complaining of the symptoms. Nobody complains of hyperlipidemia or microalbuminuria, or they need an antiplatelet. We do all this as a preventive measures to prevent the serious problem, which is really important. But with doing this without enough clarity, we end up with a big wall between us and our patients. So really, we need to clarify things a bit better, communicate to our patients in a bit better, and avoid using language that is difficult to our patients or threatening to our patients. I remember one of my patients said, I did not understand anything last time. The colleague was using long, difficult sentences. So our language needs to be simple, and we need to stop threatening our patients that I've done my best, next time is an injection, next time it's insulin, because that makes the patient really very fearful of insulin. Here is a very interesting study about physicians' communication when prescribing a new medication. This study was done in Sacramento, in California, and they videoed physicians at the time of prescribing a new drug for 185 episodes of encounters with diabetes. And as you can see, the name of the drug was not mentioned in 26%. The side effects of the drug or the duration of the therapy is not mentioned in about 2/3 of the occasions. The number of tablets and the timing of the therapy is not mentioned in roughly 45 to 40%. So clearly, our patients after a long consultation will end up being not only confused because of the concerns of us starting a new therapy, especially if it's an injection, but also about very important points. The vast majority of our patients don't have a clue of the name of the insulin that they're on or of the tablet they're on. They tell you it's the white tablet, it's the orange box, it is the insulin pen that looks gray or looks orange in color. And that really is a matter of us because we have not spent enough time to explain to our patient and clarify to our patients in a simple manner. Now, the second important point that we really need to focus on is we need to focus on education of the patient. It costs very little. We've just seen Professor Malik presenting to us the cost of one injection to lose a bit of weight $10,000 per year. That's a massive cost that the vast majority of the patients in our MENA region will never be able to get that medication. But education is very, very cost effective. It costs very little, and the outcome of it is really very important. But education needs to be done in a structured way. We do not go to school or we do not go to university and end up with a teacher deciding, today I'm going to discuss this topic. There is a sequence and there is an education, there is a curriculum that it builds on one after the other. Patient education needs to be through a structured process that can help improve knowledge and also can look into the patient's needs and improve communication. We need to understand the situation of our patients. We need to understand our patients more because we're focusing very much on the disease, and we need to focus on the person. What is the stage of this person? Are they in a stage of development, or are they having a personality coping style problem? What is the level of intelligence or cognitive function? What's the learning style that we need to address with them? All of these points, we need to address them. The psychological aspects of the patient, the stage of the illness, and we need to think of how can we overcome these problems. Whether the person is newly diagnosed or a young lady planning for pregnancy or changing insulin therapy or a doctor changing of the physician itself, what's this lifestyle they're having? Are they suddenly changing their lifestyle and we need to try to make things simple of them? The chronic complications that we know all, as well as, of course, all the stress and the psychological problems. And every stage of this would need to have a stage of the trans-theoretical model of behavior change. Behavior change is very important. Changing behavior of our patient is really quite important to try to adopt healthy habits, eating less, eating better, exercising regularly, monitoring the blood glucose levels. Yes, this will give them information and skills, but of course, this will require intrinsic motivation, and the clever healthcare professional will be able to press on the right keys to get the motivation of the patient really strong. Simple measures, for example, is the control of the portion and the choice that the food for the patient will be filling and not will be make them feel hungry. So understanding what's the calories, for example, in a bowl of salad that will give them a lot of health, but with very little calories. Understanding that they can have a healthy, hearty meal, but without necessarily having huge amount of calories. All of this could help our patients make the choices. At the end of the day, life is full of temptation. And as Oscar Wilde said, I can resist everything except temptation. So while the patient is thinking of this lovely cake that they would have to eat tonight, what is the answer for this patient? No, do not eat it, or have a small portion, or yes, have it today and go for a walk, or yes, have it today, but don't have it tomorrow and after tomorrow and the day after. So many of the important tasks is to motivate our patients, to get them at the right path, and all of this could happen through patient education. Motivation of our patient is a must, and it needs to be in a non-confrontation labeling attitude. When you see your patient coming into your clinic and this patient is clearly overweight or obese, we automatically perhaps get into a mode of, well, you are with this problem because of what you do for your life. But we need to start thinking and putting ourselves into the shoes of this person so that we can help them with strategies and with plans that can help them change their pattern of life in a positive way. So another important point is we need to find the right persons for that role of education. Of course, education in our region is very poor and is very much underdeveloped. And this is primarily because we do not have enough diabetes educators. And when we have them, we do not have enough of them with all the tools, their personal tools, the programs, and certainly the facilities. So education needs to be done by the right person. So who would to deliver education? It's not because you're a senior person, you automatically feel you can give education. And these photos are not meant for a joke. If you were to look into, this is Boris Johnson, the Prime Minister of UK. So he is sitting in a classroom, and as you can see, he looks very miserable because although he's a quite senior politician, Prime Minister, but he's not a teacher. So he is out of his depth and he don't know what to do. In fact, he's happiest when the classroom is empty because he's out of the stress of teaching, because he is not a teacher. He is a prime minister and a politician. So we need to find the educators and empower the educators with the right tools, with the right program, and with the right facilities. Not all cramped in a small room where it is not possible to deliver the task. So they need to be trained, they need to be seeing the patient and their families in the right circumstances so that they can help their patients to improve their quality of life. Of course, the right educator would be intermingling with the family and the society and the patient to try to find the right recommendations and remove the restrictions, giving them facts and help them to make the right evaluations and help them eventually to provide solutions that is oriented to their resources and to their real life. If we do all of this, then perhaps we can have a very good investment rather than simply go for the latest drug and the latest monitor. Another very important point is the empowerment of the reluctant patient who is not keen on doing titration. So when you read here that the teaching of the patient of the self-monitoring of the blood glucose and then the dose adjustment, and this is really quite important, is something that is quite simple, but unfortunately is lacking in many places. When we initiate our patient on insulin or on an injection, our stress levels as physicians go down. But this is the moment that the stress level of the patients goes very high. So we need to try to make it simple for them and provide them with the right tool. Adherence is persistence of the treatment and compliance with the right timing and the right dose and the right circumstances. So when we're talking about insulin, is not just taking the injection, but take it with the right dose and with the right time and with the right needle. All of these factors will help the patient get the perfect outcome out of the drug rather than a semi-optimal outcome or even the negativity and the side effects of the drug. We all know that adherence is related to HbA1c. But how can we improve adherence? It must be through titration. Of course, explaining to the patient education about the timing and the insulin and the injection and all of these aspects that many of us do not have the time to do it in clinic. And here is the role of the support of the patient educator. But giving your patient a very simple titration algorithm is really quite important. We have seen in this simple, important trial that the vast majority of hypoglycemia occurs in the first 8 weeks of insulin initiation. So if we can overcome this, it would be really important. This is the titration algorithm that we adopted in one of our recommendations for Ramadan, for mixed insulin. That simple titration algorithm, which is of course in Ramadan different than normal days, was adopted. Riaz mentioned the RISE-VEC trial, which I took part, where IDIC-ASP and BI-ASP30 were both compared. And I'm not showing here this to compare the benefits of one drug or the other. No, I am simply showing this to show you that when the patient are well educated with a titration method, you can see the dose of insulin at 0 time started with about 20 to 25 units. By the time Ramadan started, it was 37 units. Come first day of Ramadan, they were advised to reduce the suhoor dose by 40%. So it was reduced to 21 units. Come first day of Eid, they were invited or advised to go back to the normal dose. And that happened regardless of the type of insulin. While the other injection gradually increased to match the needs of the patient and remained stable during the month of Ramadan, because that was the injection at the eating time. So what happens is the patient have very good control and the hypos were less because of the pharmacodynamics. So really, if we teach our patients, they will learn. And it's interesting that the mirror image of the word teach is learn. If you put a mirror here, that's the word learn. If we go home today and all of us have learned something, that will be really important. Education works. When we applied education for patients in London, in Wembley area, for hypoglycemia prevention in Ramadan, it worked. It worked actually even better than before Ramadan. And it helped our patients to have a stable HbA1c and weight reduction as well. So what is really important is to think of education as a very cost-effective and a simple tool. We won the first prize from Diabetes UK twice and from ESD once. So all of this because of simple patient education. So ladies and gentlemen, I think we have plenty of challenges and plenty of barriers for injectable therapy. Of course, finding the right drug is very good. And we have heard today about the availability of some of the important and better types of injections that we have available. But let's not forget, number one, we need to eliminate the negative language. We need to remove the threat to our patients. You're failing in your treatment and I will need to give you an injection. No, that should really change. We need to find diabetes educators and empower them with all the tools so that they can deliver their task specifically for patients who need to understand the drug, the monitoring, the titration, the injection, many aspects of this. For our patients who are reluctant to take the therapy and eventually agreed, they need to be empowered with a titration regimen that is very easy for them and easy to apply on a daily basis or weekly basis. And finally, we need to focus on education as the most important tool with the right curriculum that is related to our patients and our region, not something that we can simply get from another place, because the culture and the language and the style of life in every place is different than the other, even though they all have diabetes. So I would like to conclude with, we perhaps need hospitals, perhaps we need more healthcare professionals, doctors, nurses, dietitians, perhaps we need more medicine. I'm not sure that we need all of this, but I'm sure that we need education, which Nelson Mandela said is the most powerful weapon which you can use to change the world. Thank you very much, and I look forward to your questions in the question and answer time.
Thank you, dear Professor Mohammed Hassanin, for your very, very interesting lecture and for all your efforts in the organization of the IDF MENA Blue Circle webinar. Your lecture shows the importance of the motivation of patient, listening to patient, and spending a lot of time with patient and his family in structured function, and it's important what you defined. Now we start the session of questions, and there are many questions for the speakers, and I hope that the answer will be very short to give more information to attendees. Sabrina Bouzerzour, she asked GLP-1 or SGLT2 inhibitor can replace statins in primary prevention. Professor Rash Malik.
No.
Another question, can be used GLP-1 in NEFLD stage F3, F4 at fibroscan?
No good data.
Another question about are SGLT2 inhibitor basic insulin association more beneficial than GLP-1 basic insulin association in type 2 diabetes?
I think there are the candidates for the two combination. There are candidates for SGLT2 inhibitors, like candidates with heart failure and candidates with ischemic cardiovascular disease or high risk of cardiovascular disease. There are candidates for GLP-1 receptor agonists.
Question for Riaz Malik. Liraglutide may increase heart rate as compared to other GLP-1 receptor agonists?
Perhaps, but it improves cardiovascular outcomes.
Okay. Can we use GLP-1 in obese type 1 diabetes?
There is a trial, the adjunct therapy, the adjunct trial. The aim of adjunct trial is to evaluate safety and efficacy of liraglutide in type 1 diabetes.
But perhaps for the simple doctors or the less experienced doctors, nothing has been established yet that it's a tool to be used for type 1 diabetes. There are still research and experimental trials, but the drugs and the efficacy and safety have not been established yet.
And there's no license as well at the moment. The only
Yes.
drug is with pramlintide, which is the amylin agonist.
Question from Rasul Mehdi. What precautions to be taken before starting GLP-1 receptor agonist?
Well,
pancreatitis and hypertriglyceridemia.
Is there any difference of glycemic control with insulin degludec aspart combination versus basal bolus insulin therapy in Asian, European, or Americans?
I can take that one.
Yeah.
From the Ryzodec trial that we did, obviously the results were very comparable of the data to what we saw in efficacy trials, stage 3 trials in Western societies. And obviously the Ryzodec trial in Ramadan was on patients from Middle East and Asia. So the outcome is identical. The benefits are identical. If anything, you can even argue that in some of these studies, the Asian subgroup responded even better.
Thank you, Hassanin. Question for Munis Wami. Insulin degludec lira needs at least 12 to 14 months or weeks to get good control or uncontrolled blood sugar. As per the charts, do we need to wait for such a long period?
I think most trials in terms of effect on glucose were done short term, actually, 24 weeks maximum. So, you know, I don't know. I don't know how to interpret that question. And most of the benefit was early on in the first 3 to 4 weeks. I think the key thing is, as Mohammed said, is actually education and adequate titration of these therapies. The problem is that sometimes what we tend to do is we just put them on a dose and then leave them for 3 months. That's the wrong thing to do.
Exactly.
What's the best time to use GLP-1 receptor agonist?
You mean best time of the day or best time in the disease process?
It's not clear. I think that it's
time of the day.
The day.
Well, if it's of the day, it's, I mean, usually with the meal, if it's for once daily. But for the weekly ones, it's any time. But for the disease process, I guess when postprandial problems combined with fasting hyperglycemia, if you're going to use the combination. But if you're just going to use a GLP-1, it's in a person who has postprandial hyperglycemia and you want to improve the weight as well, and after all can afford the therapy, because the therapy is not cheap.
I think in terms of the question, in terms of when you might give it in relation to food, certainly when exenatide first came out, we were always told to give it not at the same time as food because of the nausea and the side effects of the short-acting ones. But I think I don't actually say to them, take it at the time of food. You know, really should be a space either side of the food.
Thank you, Malik. Maher Talas asked about combining weekly GLP-1 with basal analogs.
Yeah, that's, to me, no problem if you're on a once a week. I mean, the data suggests from the combinations that the Injectable and the other compound, which is the lixisenatide with glargine, but they are more once daily agents that were, you know, used. So if you have a patient already on a once weekly, then there's no issue, I don't think, with giving the basal background insulin. And in fact, of course, in the future, we may well see a combination of something like semaglutide with the new icodec, you know, which is once a week.
I guess the issue here is only a difference in one injection per week. If you have the two together on a daily basis, you have 7 injections per week. If you have the weekly GLP-1, then you end up with 8 injections per week. So the difference is not massive. Of course, patients would like not to have 2 injections on the same day, but if it's once a week, it's not such a big problem. What's important is that they comply with both and take them at the right dose.
Thank you, Hassanin. Question for Kenza. What about gastrointestinal side effects with insulin degludec lira compared with liraglutide treatment alone?
The association doesn't increase the gastrointestinal side effects like nausea or vomiting or diarrhea.
Actually, if anything, you get less because you have a lower amount of GLP-1 because the insulin is also working with it.
Question to Professor Malik. Cardiovascular outcomes of oral semaglutide, please.
So far, there is a short-term trial that does show some benefit, but it's not been powered. It wasn't actually originally powered to show, and there is a big trial going on. But there is a trial published, I think it's in JAMA or New England, that did show a trend for benefits.
Can we use insulin degludec lira with sulfonylurea?
Yes.
Yeah, no problem.
Yeah.
Because the insulin here is the basal insulin, and you can always use a basal insulin and sulfonylurea at the same time.
is it better to use the combination of degludec and lira than glargine lixi?
Loaded question. You know, honestly, if you look at the data, they're pretty comparable. I mean, some might argue that the lixi zenatide has got more postprandial effects. Liraglutide has more kind of weighted towards the, you know, the preprandial. But I think we need to see long-term data. I personally think ultimately the end game is cardiovascular outcomes. And I think once those trial data are through, we'll be clearer as to where these new therapies stand.
Can I ask a question to my colleagues here? We've heard a lot of focus today on the discussion on the cardiovascular outcome trials. But my personal slight concern is the patients in these trials are a special group of patients, special in their age, special in their pathology, where vast majority of them either have end organ damage or high risk. My slight concern is people are mixing the information and generalizing that, especially in an area where we see newly diagnosed patients in their 20s and their 30s, early 30s. So in your opinion, is there a difference between the UKPDS and the likes of this, where the patients were started on insulin in the very beginning of the disease process, in comparison with the cardiovascular outcome trial, where patients have 10 plus years of diabetes and they are 50 plus of age and with a pathology? Do you feel these trials are comparable, or they are very different trials?
Kenzo, do you want to answer to that? Or, I mean, I think there clearly are different trials in terms of the natural history. UKPDS was at diagnosis, and all the other big Accord, VADT, the other one I can't remember, were all people with established cardiovascular disease. But does that make a difference? No. I mean, I think the GLP-1 agonist trials clearly show that, you know, this is, and the SGLT2 inhibitor trials show that this is where you're going to get the benefit.
Another question about semaglutide for weight loss. Can it be given in pregnancy?
No, like.
No.
How to down titrate the dose of insulin if we want to add GLP-1?
It depends of the A1C and the target of A1C. If the patients are in the higher A1C, I think there is any necessary. It's not necessary to down titrate the dose of insulin. But if the A1C is above the target, I think we must down titrate it for 20%.
Question from Suleiman. What's cutoff value of eGFR at which GLP-1 agonist should be used?
I can take that. I used to do the diabetic nephropathy clinic. Liraglutide could be used up to a very low eGFR. They're pretty safe. So from that point of view, there is not such a big issue. So you can carry on with eGFR up to 15 if you wish. I do not know the exact license for that issue, but I'm talking about in clinical practice where you have a patient well controlled. From a safety point of view, there is no issue. What is the actual license? I'm not sure. Any of you guys know?
I think it's 30 for liraglutide.
Another question about sulfonylurea can be used with the DPP-4 inhibitor? Yes.
Yes, no problem.
Yes. No problem. Yes. Question about the maximum dose of glargine.
As much as you...
When the fasting glucose is very well controlled.
So it depends, you know. I mean, honestly, I had a patient with extreme insulin resistance once, some rare receptor, and he was on 2,000 units. So, you know, so really there is no upper limit. I've just looked up actually EGFR less than 30. If we do not recommend Victoza, avoid if EGFR less than 15, and Lixisenatide avoid if EGFR less than 30.
Question from Professor Hassanin. What about the family role in overcoming the barriers?
Very important role, and that's why in our educational sessions we invite the patient with their caregivers, whether that is a family member or a non-family member. It's really very important. It's not just about the drug, but it's about what you eat, what you want to do. So engaging with the family members is very important.
Can we add semaglutide 2.4 for obese patients with HbA1c 7% or less to reduce obesity in this patient?
Well, it is licensed for obesity regardless of diabetes. So, or at least that's the latest license. So, so it should be similar to Saxenda, similar to the liraglutide 3 milligrams, where it is licensed for obesity treatment regardless of diabetes.
Another question from Bayaqub. Can we start insulin in patients with diabetes control, HbA1c, but uncontrolled fasting blood sugar?
I'm not sure we understand the question.
HbA1c is controlled, but uncontrolled fasting blood sugar. I think it's not necessary to use insulin if the blood sugar is controlled.
Yeah, HbA1c is fine, that's fine.
What about some physicians are not considered that referring the patient to diabetic educator is important. How to solve that?
Yeah, the vast majority of the physicians in our region do not have patient educations because they are not convinced about it. If they are convinced of the drugs, they go and fight for the drugs and ask their patients to pay for the drug or their organization to pay for it. And as the way I see it is, we need the basic education for our patients. Otherwise, they will not benefit from these very expensive drugs. So it is really important for us to be convinced about the role of education, especially with physicians who are very busy in their clinics, where they're seeing 20, 30, 40 patients in a clinic. How can they provide the right care? So they need the support of a well-trained patient educator or diabetes educator.
Question from Maher. Is in long-standing diabetes, is basal bolus better than choice than GLP-1 basal combination?
No reason to think just because you've got so-called long-standing diabetes that I think it's, you know, if the patient is overweight, for example, I would definitely still want a GLP-1 in there. And if it works adequately with the combination of the basal with the GLP-1, better than basal bolus, it's probably better because if you have a patient who's had a long-standing diabetes, an older patient, they have an increased risk of hypo. So you want to avoid that.
I mean, in all honesty, Jamal, if you think about it, this is one injection a day and the other one is multiple injections. So to find a person for the multiple injections means we need to find this person. Patient lifestyle is terribly variable from day to day. That maybe is and committed and willing to check and willing to take more injections. But otherwise, studies is just throw everyone into option A or option B. In real life, we select who's suitable for this and who's suitable for this. I
think the last question probably about from Kenza. What about synergetic effects in combining SGLT2 inhibitor and GLP-1 agonist?
Regardless of the price, it's a very good combination.
There are actually currently trials that are ongoing looking at that.
What best oral drugs to control postprandial hyperglycemia?
DP4 inhibitors are good.
Sulfonylurea.
Sulfonylurea would be good as well,
Yeah.
especially the shorter acting ones.
Yeah.
Type 1 diabetes in pregnancy, what new of GLP-1?
No GLP-1 for type 1 diabetes or type 2 diabetes. No studies because it has a potential of teratogenic effect.
Is GLP-1 can be used for type 1 more than 8 years? Thank you, dear speakers, from all your response. And before closing this session, I would like to thank deeply the speakers, Professor Riaz Malik, Kenza Ben Omar, and Professor Hassanin, the organizer of this webinar, Amber event, and all the participants and the attendees from MENA region and outside MENA region. And thank you for this question and for this discussion.
Thank you very much, Professor Jamal, for the kind, nice moderation. Lovely working with all the speaker, Kenza Ben Omar and Riaz Malik.
Good evening, and see you later in the next webinar.